Right now, inside your intestinal tract, there are approximately 39 trillion bacteria. That number isn't metaphorical. It's the actual estimate from a 2016 paper in Cell that recalculated the human microbiome census with unprecedented precision. 39 trillion. And the reason I'm starting there with that number is because buried inside that ecosystem are bacterial communities doing something that most oncology conversations have never adequately explained to the women who need to hear it most. They are actively regulating your cancer risk, not passively, not incidentally, actively. I'm Dr. Jessica Ward, Integrative Oncology researcher. I've spent 15 years reviewing the scientific literature on cancer prevention, tumor biology, and women's cellular health, with a specific focus on what changes in female biology after menopause. Because the hormonal shift that happens at menopause doesn't just affect hot flashes or bone density. It reaches into the gut, fundamentally alters the microbial ecosystem living there, and triggers a cascade of changes in how your immune system detects cancer cells, how your body metabolizes estrogen, and whether the bacterial communities that are supposed to be fighting on your behalf are still equipped to do so. Before we go further, I need to be direct about something important. Everything I'm covering today is educational information based on peer-reviewed research. It is not medical advice and is not a substitute for your care team. If you have a diagnosed cancer, are in active treatment, or are taking medications for a hormone-sensitive condition, please bring this information to your oncologist or physician before making changes. That said, the research I'm about to walk you through is some of the most compelling evidence I've encountered in 15 years of reviewing this literature, and it exists specifically for women in your hormonal window. Here's what almost never gets explained clearly. The research on gut bacteria and cancer has historically centered on colorectal cancer, and it has historically centered on men. What's been consistently overlooked is a system that is uniquely and specifically female, a subset of gut bacteria called the estrobolome, which exists to metabolize estrogens, which operates completely differently once ovarian estrogen production ends, and which the National Cancer Institute has now directly linked to breast cancer risk in post-menopausal women. That connection, bacteria, estrogen metabolism, cancer risk, and the hormonal window you're currently in, is exactly what today's investigation covers. Most general health advice about gut bacteria tells you to eat yogurt and avoid antibiotics. That advice is fine, but it was designed without your biology in mind. What the women-specific data actually shows is that the microbial changes that happen after menopause are dramatic enough that a post-menopausal woman's gut microbiome more closely resembles a man's than it resembles her own microbiome from 20 or 30 years ago. Researchers have called this masculinization of the female gut, and understanding why it happens and what it means for cancer risk specifically in women over 60 changes the framework entirely. Today, you're going to understand what the estrobolome is and why its collapse after menopause matters for breast and endometrial cancer. You're going to see the 5 biological mechanisms through which gut bacteria influence cancer, including what changes in each one when estrogen disappears. And you're going to leave with a specific, evidence-supported protocol calibrated for postmenopausal biology, not for a general population that doesn't share your hormonal reality. If you're finding this research valuable, subscribing to the channel takes 1 second and it helps me keep doing this work. There's no pressure. I just genuinely appreciate the support, and it makes a difference. Let me start with where the evidence pointed me first. Scientists at the National Cancer Institute documented something that should be in every conversation about cancer prevention in women over 60. They studied the gut microbiomes of postmenopausal women, comparing women who had developed breast cancer against healthy postmenopausal controls. And what they found was unambiguous. The women with breast cancer had measurably less microbial diversity in their intestinal tracts, not slightly less, significantly less. And the composition was altered in specific ways that the researchers identified as functionally meaningful, not just incidentally different. This work was documented by the American Society for Microbiology in 2025, and it's important because it draws the line directly from gut microbiome to breast cancer risk in the exact population we're talking about, post-menopausal women. But that finding alone didn't explain the mechanism, it told me there was a relationship. It didn't tell me why. So I went looking for what was actually happening inside the gut. A 2025 systematic review published in the International Journal of Cancer, authored by Larnder, Manges, and Murphy, focused specifically on what they called the estrobolome. The estrobolome is the collection of gut bacterial genes responsible for metabolizing estrogens. Not all gut bacteria participate in estrogen metabolism, but a critical subset do, and they use an enzyme called beta-glucuronidase to do it. Here's what the research showed. Disruptions in how the estrobolome functions are directly associated with changes in circulating estrogen levels, and those changes in estrogen levels are associated with breast cancer risk. Two specific bacterial families, Clostridiaceae and Ruminococci, which are rich in beta-glucuronidase genes, showed strong associations with urinary estrogen levels and microbiome richness in case control studies. This is the research that began to explain the mechanism the NCI finding was pointing toward. I want to be honest about one scientific nuance here, because the literature demands it. The Larnder review found that results across case control studies are heterogeneous, meaning different studies don't all point in exactly the same direction with uniform magnitude. The field is maturing, the biological logic is strong, the mechanistic evidence is compelling. But I wouldn't characterize this as settled science with the same level of certainty as, say, the relationship between smoking and lung cancer. What I can say is that the convergence of evidence across multiple independent research groups, the biological plausibility, and the specificity to postmenopausal biology make this a research area that deserves serious attention, and that's exactly how I'm presenting it to you. Moving forward in the evidence trail, a 2022 review in the International Journal of Women's Health, led by Peters, Santoro, Kaplan, and Chi, drawing in part on data from the Hispanic Community Health Study, made a finding that I think is underappreciated in most conversations about menopause and health. They confirmed what researchers had been theorizing. The relationship between the gut microbiome and hormonal levels is bidirectional. The microbiome affects estrogen levels, but estrogen levels also affect the microbiome, which means that when ovarian estrogen production ends at menopause, you don't just lose one half of that equation, you lose both simultaneously. The gut loses its estrogen-mediated regulatory signals, and the microbiome shifts in ways that then further alter how estrogen residuals are metabolized. The Peters review specifically identified that postmenopausal women show alterations in the estrobolome and gut microbiome with direct implications for adverse cardiometabolic risk, and that these correlations are actually stronger in postmenopausal women than in premenopausal women. That last point matters. Postmenopausia is not just a time when the microbiome changes. It's the time when the microbiome's effects on health outcomes are most consequential. The evidence on endometrial cancer added another dimension. A 2021 systematic review in the Journal of Clinical Medicine analyzed 15 relevant studies and found 4 independent studies confirming that postmenopausal status increases firmicutes and decreases bacteroidetes in the gut, raising what researchers call the firmicutes to bacteroidetes ratio. And that ratio shift is associated with greater beta-glucuronidase activity, which means more deconjugation and reabsorption of estrogens. The clinical implication in women is direct. More circulating estrone, which is the dominant estrogen after menopause, stimulating estrogen receptor-positive tissues, including endometrium. Endometrial cancer is the most common gynecological cancer, and its incidence rises dramatically after menopause. The research suggests that gut microbial dysbiosis may be one of the overlooked mechanisms driving that increase. The study that anchored my understanding of how estrogen-specific this all is came from researchers at the National Cancer Institute, published in the Journal of Translational Medicine in 2012. The lead author was Flores, and the sample was specifically 35 postmenopausal women. What they measured was precise: the relationship between fecal microbial profiles and both fecal and systemic estrogen levels. The finding was that the microbial community in the gut, directly determined how much estrogen was circulating systemically. Women with greater microbial diversity had better balance between active estrogens and their metabolites. And critically, beta glucuronidase showed its strongest correlation in postmenopausal women specifically. In premenopausal women, that correlation wasn't there with the same strength. This was the first study establishing the chain directly: microbiome composition to estrogen circulation to hormonal exposure risk in postmenopausal women as the specific population. And then there's the masculinization finding, which I think is one of the most striking pieces of data in this field. Across multiple independent analyses, including work synthesized in a 2022 biology review on the gut microbiome and female health, researchers documented that the gut microbiome of postmenopausal women shifts compositionally to resemble men's microbiomes more than it resembles the microbiomes of younger women. Lower abundances of Bifidobacterium, allostype species, and certain Ruminococcus species. Higher Bacteroidetes and Tolumonas, a pattern associated with male gut ecology. The loss of bacteria that produce short-chain fatty acids at low caloric load. This isn't a minor compositional shift. It's a fundamental reorganization. And it has direct consequences for how well the bacterial communities can produce cancer-protective metabolites. Now, let me take you through the 5 mechanisms that connect all of this to cancer biology, because understanding the mechanisms is what makes the protocol actionable. The first and the most uniquely female is the estrobolome itself and what happens to it when estrogen disappears. The liver does its job diligently. It takes estrogen, conjugates it, essentially wrapping it in a glucose molecule to inactivate it, and sends it out via bile into the intestine for excretion. This is how the body handles used estrogen. It wraps it up, ships it out. What happens next depends entirely on the bacteria waiting in the colon. Specific bacteria carry the enzyme beta glucuronidase, which unwraps those conjugated inactive estrogens, deconjugating them, reactivating them, and making them available for reabsorption back into the bloodstream through a process called enterohepatic circulation. How much reactivated estrogen gets recirculated depends on how much beta-glucuronidase activity exists in the gut, which depends on which bacteria are present and in what proportions. Before menopause, this system was balanced in ways we're still fully characterizing. Estrogen itself helped maintain the microbial communities that kept the system in equilibrium. After menopause, 2 things happen simultaneously. Estrogen production from the ovaries essentially stops, and the gut microbiome loses its estrogen-mediated regulatory input. The result is dysbiosis, bacterial imbalance that can push the system in either of 2 problematic directions. If dysbiosis leads to excess beta-glucuronidase activity, you get over-reabsorption of the residual estrogens still present in the post-menopausal system, primarily estrone, creating what the research describes as a low-level chronic estrogenic exposure without the protective benefits of physiological estradiol. That chronic exposure reaches estrogen receptor-positive tissue in the breast and endometrium. If dysbiosis leads to insufficient beta-glucuronidase, the estrogen balance tips the other way. The diversity of the estrobolome is what kept this calibrated, and that diversity declines after menopause. Think of the estrobolome like the editorial department at a publishing company. Estrogen is the manuscript coming through. Before menopause, the editorial team was large, experienced, and well supervised. They reviewed each manuscript carefully, decided what to recirculate and what to archive. After menopause, half the editorial staff left because the organizational structure that funded their positions disappeared with estrogen. Now some manuscripts are recirculated that shouldn't be, and others are buried that should be reviewed. The calibration is gone. The Flores et al. Study, with its 35 postmenopausal women, was the first direct demonstration that microbial profiles determine the estrogen levels in postmenopausal women's bodies. The estrobolome is not a peripheral biochemical curiosity. For women in your hormonal window, it may be one of the most important cancer-relevant systems in the body. The second mechanism is more direct, and it connects specifically to colorectal cancer risk. Beneficial bacteria, Lactobacillus species, Bifidobacterium, Fiacalibacterium prausnitzii, Roseburia, Lachnospira, ferment dietary fiber. That fermentation produces short-chain fatty acids, the most important of which is butyrate. And butyrate does something remarkable at the cellular level. It inhibits a class of enzymes called histone deacetylases, or HDACs, inside cancer cells. HDAC inhibition is actually a recognized mechanism in cancer pharmacology. There are approved HDAC inhibitor drugs for certain cancers. Butyrate is the gut's natural bacteria-produced version of that inhibitory signal. In the colon specifically, where butyrate concentrations are highest, this translates to induction of apoptosis in cancer cells, promotion of differentiation in cancer cells, making them less aggressive, and fortification of the intestinal barrier itself through reinforcement of tight junction proteins. The menopause layer here is this. After menopause, the bacteria that produce butyrate are among those that decline most consistently. Roseburia and Lachnospira, both significant butyrate producers, are documented to decrease post-menopausia. Fiacalibacterium prausnitzii, arguably the single most studied anti-inflammatory bacteria in the human gut, also declines with age and with the dietary shifts that often accompany aging. And estrogen itself, it turns out, was helping optimize the cellular response to butyrate by maintaining the expression of receptors called GPR41 and GPR43 on intestinal epithelial cells. Without estrogen, the intestinal cells become less responsive to butyrate even when it is produced. This creates a compound vulnerability. The bacteria that make butyrate decline. The cellular machinery that responds to butyrate also becomes less sensitive. The colorectal cancer protection that a diverse, fiber-fed microbiome provides is diminished on two fronts simultaneously. Think of butyrate as a stop signal, a cellular message that tells cancer cells to pause, differentiate, and in many cases, to initiate their own death. After menopause, your gut is producing fewer of these stop signals, and the signal receivers have become partially hard of hearing. The question is whether you can turn up the volume again through diet. The research says yes, and I'll cover exactly how in the protocol section. The third mechanism involves what happens to the physical barrier of the gut itself. The intestinal lining is not simply a passive wall. It's an actively maintained structure, sealed between cells by proteins called tight junction proteins, claudin-1, occludin, ZO1. These proteins keep the intestinal contents separated from the bloodstream. When they function well, the bacteria in the gut stay in the gut. When they fail, small amounts of bacterial components, particularly a molecule called lipopolysaccharide, or LPS, found on the outer membrane of gram-negative bacteria, can escape into circulation. When LPS enters the bloodstream, the immune system recognizes it as a bacterial invader and mounts an inflammatory response. When this happens chronically, at low levels continuously, day after day, researchers call it metabolic endotoxemia, and metabolic endotoxemia creates a systemic inflammatory environment. Estrogen was maintaining tight junction protein expression in the intestinal epithelium. A 2024 paper in Microbiome by Gaber and colleagues found that visceral adiposity in post-menopausal women was associated with a pro-inflammatory gut microbiome and immunogenic metabolic endotoxemia. Post-menopausal women, particularly those with central weight gain, show elevated markers of intestinal permeability and systemic inflammation, HSCRP, IL-6, TNF-alpha, that correlate with changes in gut bacterial composition. And chronic low-grade inflammation is one of the recognized factors in creating a tumor-permissive systemic environment. The estrobolome disruption and the butyrate depletion both contribute to this permeability. The bacteria that maintained tight junction integrity, particularly Lactobacillus and Akkermansia mucinifila, which physically reinforce the intestinal mucosa, decline post-menopausically. The bacteria producing butyrate, which strengthens tight junctions from the inside, also decline. It's a coordinated deterioration, not a single point of failure. Before menopause, your gut lining was like a carefully maintained wall with a dedicated maintenance crew. estrogen and the microbial community's estrogen helped sustain. After menopause, the maintenance budget was cut, the crew was reduced, and the cracks started appearing. And what leaks through those cracks, LPS, bacterial fragments, triggers the chronic inflammation that doesn't cause symptoms you'd notice, but creates a biological environment that's meaningfully friendlier to cancer cell survival and proliferation. The fourth mechanism is one that connects gut health to the broader immune surveillance system, and it may be the most far-reaching. Approximately 70 to 80% of the immune system is anatomically located in and around the gut. This isn't coincidental, it's architectural. The gut is where the immune system faces the largest daily challenge, distinguishing between beneficial bacteria, commensal microorganisms, food antigens, and actual pathogens. The microbial communities of the gut educate and calibrate the immune cells stationed there. They influence natural killer cells, cytotoxic T lymphocytes, the CD8 positive T cells, and regulatory T cells. A diverse, balanced microbiome educates NK cells to be functional and aggressive against cancer cells, and TCD8 plus cells to maintain active tumor surveillance. A dysbiotic microbiome does the opposite. It promotes immune tolerance, shifts the balance toward regulatory T cells that dampen immune responses, and reduces the active surveillance that catches precancerous cells before they progress. The mechanisms here are specific. Bifidobacterium and lactobacillus species induce production of interferon gamma by NK cells, which is one of the primary signaling molecules that activates NK cytotoxicity against cancer cells. Faecalibacterium prausnitzii produces butyrate and anti-inflammatory peptides that activate anti-tumor T lymphocytes. There is also now strong clinical evidence that Akkermansia mucinifila specifically improves response to checkpoint immunotherapy, anti-PD-1 therapy, in patients with lung cancer and melanoma. The microbiome is not peripheral to the immune system's anti-cancer function. In some contexts, it may be central to it. The menopause layer here involves a compound effect. Estrogen was modulating NK cell activity directly through estrogen receptor beta expressed on NK cells themselves. Post-menopause, NK cells lose that hormonal modulation. Simultaneously, the microbial communities that were educating and activating NK cells decline. Women after menopause who also have gut dysbiosis face a double loss of NK cell function. The hormonal signal is gone, and the microbial trainer is understaffed. The research in post-menopausal women with breast cancer from the NCI documentation of reduced microbial diversity likely reflects this compound deterioration in immunosurveillance. Think of the gut microbiome as the training program for your immune army. Every day, the beneficial bacteria are running drills, teaching the NK cells and T cells what cancer looks like, how to respond, how hard to hit. After menopause, you've lost the hormonal co-trainer, and the microbial training program is running with a skeleton crew. The army is still there, but without consistent, intensive training, its ability to catch early-stage cancer cells before they proliferate is meaningfully reduced. The fifth mechanism involves specific bacteria doing specific oncogenic damage, and specific bacteria providing specific protective inhibition of cancer pathways. In 2024, a paper in Gut Microbes identified a mechanism worth understanding carefully. Prevotella copri, a bacterial species that tends to increase in postmenopausal dysbiosis, was shown to deplete a metabolite called indole-3 pyruvic acid from the host. Indole-3 pyruvic acid is important because it activates AMPK, a metabolic sensor that acts as a tumor suppressor. When Prevotella copri depletes indole-3 pyruvic acid, AMPK activation is reduced via a protein called UHRF1, and breast cancer cell progression is promoted. This isn't a theoretical pathway. It's a documented mechanism from a peer-reviewed study describing how a specific bacteria that postmenopausal dysbiosis tends to favor is working against you at the molecular level. On the genotoxic side, certain strains of E. coli that carry what's called the PKS genomic island produce a compound called colibactin, which directly damages DNA in colonic epithelial cells. This is a recognized mechanism in colorectal carcinogenesis. Fusobacterium nucleatum, which is elevated in colorectal cancer tissue and implicated in its progression, produces proteins that activate the WWNT beta-catenin pathway, a major driver of cancer cell proliferation. What counterbalances these pathogens are the bacteria producing short-chain fatty acids and the metabolites that inhibit oncogenic signaling pathways, including WNT, NFKB, and STAT3. Bifidobacterium and lactobacillus maintain the equilibrium. When postmenopausal dysbiosis tips the balance, more Prevotella, more inflammatory proteobacteria, less bifidobacterium, less Faecalibacterium, the scale tilts toward a gut environment that is quietly permissive of cancer initiation and progression. The biology here isn't a single mechanism, it's a system, and the hormonal shift of menopause affects nearly every component of that system simultaneously. Now, I want to address something that I hear framed as conventional wisdom because the research tells a more nuanced story. The general advice, eat more fiber, take a probiotic, is directionally correct. But the research on postmenopausal women shows that the type of fiber, the diversity of fiber sources, and the specific bacterial targets matter considerably more than general population recommendations suggest. The doses that move the needle in postmenopausal women are higher than what most dietary guidelines recommend, and the timing and form of fermented foods affects which bacterial populations benefit. Let me give you the evidence-supported specifics. Before I do, one more note for safety. If you are currently in active cancer treatment, including chemotherapy or immunotherapy, please talk to your oncologist before making significant changes to fermented food intake or starting probiotic supplements. In immunocompromised states, including those created by active treatment, certain probiotics carry a small but real risk of bacteremia, bacterial translocation into the bloodstream, and that conversation needs to happen with your care team. If you have had a hormone-sensitive cancer diagnosis, breast cancer, endometrial cancer, the specific recommendations around lignans and fiber should be discussed with your oncologist. The information that follows is for women using these tools preventively, not as a replacement for active medical care. Also, everything I'm about to share is meant as a complement to your existing care, not a replacement. If you're under medical supervision for any condition, bring this research to your physician and decide together what makes sense for your situation. The first and most impactful priority is dietary fiber, specifically 30 to 50 grams per day. Most postmenopausal women are consuming between 12 and 15 grams per day. That gap matters. The research on what moves the estrobolome, supports butyrate production, and maintains microbial diversity consistently points to fiber as the single most powerful dietary lever. But the type of fiber matters for specific bacterial targets. Inulin and fructooligosaccharides found in garlic, onions, leeks, asparagus, and Jerusalem artichokes selectively feed bifidobacterium, which is among the most consistently depleted bacterial genera after menopause. 1 tablespoon of raw garlic or half a cup of cooked asparagus meaningfully shifts the fermentation substrate toward bifidobacterium. Resistant starch, found in green bananas, in potatoes that have been cooked and cooled, in oats that have been cooked and cooled overnight, specifically supports Faecalibacterium prausnitzii, the anti-inflammatory butyrate producer that declines with age and poor diet. A cooked and cooled potato has roughly 3 times the resistant starch of a freshly cooked one because cooling converts digestible starch to resistant starch through a process called retrogradation. Beta-glucans from oats, barley, and culinary mushrooms support Akkermansia mucinifila specifically, the bacteria that physically restores the intestinal mucosa, as well as natural killer cell activation through direct immunomodulatory signaling. 30 grams of rolled oats provides approximately 3 to 4 grams of beta-glucan. Pectins from apples, citrus pith, and berries support lactobacillus populations and tight junction integrity. And polyphenols from blueberries, raspberries, and blackberries at roughly 1 cup per day do something specific that other fiber sources don't. They suppress the growth of pathogens like E. coli and Clostridium while simultaneously feeding bifidobacterium. The mechanism is that polyphenols are poorly absorbed in the small intestine, arriving largely intact in the colon where bacteria metabolize them into active anti-inflammatory compounds. For the estrobolome specifically, fiber does something else beyond feeding beneficial bacteria. It physically binds to conjugated estrogens in the intestinal lumen and carries them out in the stool, reducing the amount available for bacterial deconjugation and reabsorption. Women with higher fiber intake consistently show lower circulating estrogen levels, a finding that has direct implications for ER-positive breast cancer risk in post-menopausal women. Incrementally building toward 30 grams per day over 3 to 4 weeks will minimize the bloating and gas that accompanies a rapid fiber increase, because the microbial population needs time to expand before it can efficiently ferment the increased substrate. The second priority is fermented foods, strategically chosen. Kefir is the most evidence-supported fermented food for post-menopausal microbiome restoration. It contains Lactobacillus acidophilus, Bifidobacterium lactis, Lactobacillus kefiri, and several other species depending on the culture. Typically 12 to 15 strains in traditionally made kefir versus 2 to 3 in most commercial yogurts. 1 cup per day. If dairy doesn't agree with you, water kefir made from coconut water or plain water with kefir grains provides a non-dairy alternative with similar bacterial diversity. Traditional miso, specifically unpasteurized miso, which retains live cultures, provides Aspergillus oryzae and supporting bacterial communities with well-documented anti-cancer properties in Japanese cohort data. Half a tablespoon in a soup that's not boiling preserves the live cultures. If fermented foods are limited in your diet, a multi-strain probiotic supplement with Bifidobacterium lactis, B. longum, Lactobacillus rhamnosus, and L. acidophilus at 4 to 10 billion colony-forming units per day is a reasonable alternative. The evidence base for food sources is stronger than for supplements, but supplements are a meaningful bridge when food diversity is constrained. The third priority is lignans from ground flaxseed. 2 tablespoons of freshly ground flaxseed per day is one of the most specifically studied dietary interventions for the estrobolome in post-menopausal women. Lignans in flaxseed are metabolized by intestinal bacteria into enterolactone and enterodiol, phytoestrogenic compounds that at physiological doses modulate the estrogen receptor in ways that are associated with reduced breast cancer risk in post-menopausal women. This metabolic conversion from lignin to enterolactone requires specific bacterial activity, which means that the state of your microbiome affects how much enterolactone you produce from the same amount of flaxseed. Women with dysbiosis produce less enterolactone. Women who improve their microbiome diversity first will get more from the same intervention. Do not exceed 3 tablespoons per day. The weak phytoestrogenic activity of enterolactone, while associated with protective effects in population data, is a reason to keep doses in the studied range rather than assuming more is better. Quercetin deserves specific mention because of its direct effect on the estrobolome. Quercetin, found in onion, particularly red onion, apples, capers, and buckwheat, directly inhibits bacterial beta-glucuronidase activity in the gut. This is a targeted effect on the enzyme that reactivates conjugated estrogens. In postmenopausal women, where excess beta-glucuronidase activity is associated with higher circulating estrone, quercetin provides a specific tool for reducing that reabsorption. Half a medium red onion daily provides meaningful quercetin levels. The fourth priority, and I want to be direct about this one because the research is unambiguous, is minimizing the dietary patterns that dismantle the bacterial ecosystem you're working to restore. Ultra-processed foods feed E. coli and opportunistic pathogens that crowd out the protective species. High added sugar intake specifically promotes the expansion of bacteria associated with intestinal permeability. Alcohol at more than 1 standard drink per day consistently reduces bifidobacterium populations and increases gut permeability, exactly opposite of what the protocol is designed to achieve. An unnecessary antibiotic use, meaning antibiotics taken for viral infections where they have no efficacy, can deplete microbial diversity for 6 months to 2 years after a single course. This is worth knowing before you're in a situation where you might be pressured into an antibiotic prescription for a condition that doesn't require one. If you are taking antibiotics for a genuine bacterial infection, a course that's medically necessary, take it. But consider supporting microbial recovery afterward with a concentrated probiotic and a focused increase in prebiotic fiber for 6 to 8 weeks following the course. A few specific safety notes for medications common in women over 60. If you're taking tamoxifen, the interaction with gut bacteria is theoretically relevant and understudied. Tamoxifen is metabolized in part by intestinal microorganisms, and probiotic supplements that significantly alter beta glucuronidase activity could theoretically affect that metabolism. The risk is likely low, but it has not been studied directly. Have the conversation with your oncologist before starting a probiotic supplement. If you're on levothyroxine for thyroid conditions, a large increase in dietary fiber, particularly cruciferous vegetables and raw bran, can theoretically affect levothyroxine absorption when consumed close to your dose. Maintain the standard recommendation of taking levothyroxine 30 to 60 minutes before food and make fiber changes gradual rather than abrupt. If you're taking warfarin or other anticoagulants, the linen recommendation, flaxseed, has mild anticoagulant properties, and the interaction should be discussed with your prescribing physician. 2 tablespoons is unlikely to cause clinical problems, but it's information your doctor should have. In terms of what to expect and when, the gut microbiome responds to dietary change faster than most people realize. A 2015 study from Stanford found detectable shifts in microbial community composition within 3 to 4 days of significant dietary change. So, within 1 week of meaningfully increasing diverse prebiotic fibers and adding fermented foods, you'll have compositional changes underway in the gut ecosystem. You probably won't notice them directly, but they're there. In weeks 2 through 4, most people report that digestive patterns normalize or improve after the initial adjustment period. Some women note less bloating after meals, more regular transit, and sometimes less afternoon fatigue, which may partly reflect reduced low-grade endotoxemia as the gut barrier strengthens. These aren't dramatic, but they're measurable in the direction the research predicts. At 1 to 3 months of consistent intervention, 30 grams of diverse prebiotic fiber, fermented foods daily, flaxseed 2 tablespoons per day, the research suggests significant recolonization of beneficial bacteria. Studies on diet-based microbiome restoration typically show that meaningful shifts in relative bacterial abundance require 6 to 12 weeks of consistent dietary change. This is a system that operates on weeks and months, not days. At 3 to 6 months, changes in the estrobolome become detectable in studies that measure urinary estrogen metabolites. The 2012 Flores study and the broader literature on dietary estrogen modulation suggests that the estrobolome responds to dietary fiber over this timeframe, meaning the chronic low-level estrogen reabsorption that dysbiosis permits can be meaningfully reduced in a matter of months with the right substrate. What you won't have at any of these time points is a blood test. Your primary care doctor will check that directly confirms estrobolome improvement. The most accessible indirect markers are HSCRP, high sensitivity C-reactive protein, which should trend below 1.0 milligrams per liter with successful gut inflammation reduction, and stool consistency and transit patterns as functional markers. Commercial microbiome testing services like Viome or similar platforms can provide more direct compositional data, though I want to be clear that these are not medical diagnostic tests, and they're not standardized in the way that clinical laboratory tests are. They can be informative for tracking relative changes over time within the same testing platform. Let me draw together what we've covered because it represents a coherent picture that most cancer prevention conversations don't provide for post-menopausal women. You started this investigation knowing that gut bacteria are generally considered good for health. What the research shows, when you look specifically at the post-menopausal female biology, is something considerably more specific and more actionable. The gut bacteria that regulate your estrogen metabolism, the estrobolome, are disrupted by the same hormonal shift that ended your menstrual cycles. The bacteria that produce butyrate, the most potent natural inhibitor of cancer cell proliferation in the colon, decline after menopause and produce less of it. The bacteria that maintain the physical integrity of your gut lining, preventing chronic low-grade inflammatory endotoxemia, lose the estrogen-mediated support that kept them thriving. The immune training that healthy gut bacteria provide to NK cells and cytotoxic T lymphocytes operates at lower efficiency when microbial diversity falls. And specific pathogenic bacteria that dysbiosis favors, Prevotella copri, E. coli, PKS positive strains, Fusobacterium nucleatum, actively promote cancer progression through documented molecular mechanisms. What makes this different from the general gut health conversation is the hormonal specificity. Every one of these mechanisms is directly shaped by the loss of estrogen, not just incidentally affected, directly shaped. The research documented by the National Cancer Institute in post-menopausal women with and without breast cancer, the FLORAS study in 35 post-menopausal women showing that microbial profiles determine systemic estrogen levels, the Peters review establishing that the microbiome hormone relationship is bidirectional and its consequences are strongest after menopause. This body of evidence is specifically about your biology. It wasn't generated in men. It wasn't generated in younger women. It was generated in women who went through the same hormonal transition you did. The reason most of this doesn't appear in the conversations you've had with general practitioners isn't because it's not real science. It's because it sits at the intersection of microbiome research and postmenopausal oncology, which is a specialized enough territory that it doesn't always translate efficiently into primary care conversations. That's the gap this research is designed to fill. There's something worth saying plainly. Being in the postmenopausal years doesn't mean you're in a passive relationship with your cancer risk. The biology I've just walked you through is changeable, not entirely, not overnight, and not as a replacement for regular cancer screening and whatever your physician recommends for your individual situation. But the microbiome is among the most responsive biological systems in the body to dietary intervention. It is also among the most underaddressed in the cancer prevention guidance given to women over 60. The fact that you're here working to understand your own biology at this level of specificity puts you in a fundamentally different position than someone relying on generic advice that wasn't designed for your hormonal reality. Everything I've shared today comes from peer-reviewed research, not from theory, not from general population data adapted generically for women, from investigations into what actually happens in the gut biology of postmenopausal women, and from the mechanistic science that explains why the estrobolome, the immune training system, and the intestinal barrier all shift after estrogen declines. If this investigation interests you, there's a related video that goes deeper into how the immune system's natural killer cells specifically detect and eliminate precancerous cells, and why NK cell function is one of the most important things to maintain after menopause. The connection to today's microbiome discussion is direct and it's worth understanding together. Drop your biggest takeaway or your questions in the comments. I read everyone, and they shape what I investigate next, specifically for this community of women who deserve research that was actually designed for their biology. Keep investigating. I'll see you in the next one. Dr. Jessica Ward.